We're going live on YouTube in 1 second.
Good evening, Leslie. Good evening, Lori. Good evening, Kristen.
Hi.
Hi. Good evening, Rachel.
Hello. Welcome, everyone.
All right, everyone. Good evening. So glad you're here with us this evening. We are going to start in just a second here. I always like to check in with Jamila because she just runs all that stuff and she knows if we're ready. She's my good indicator of if we're ready or not.
Yeah.
Excellent. So welcome back, everyone. I hope you had a really good rest. I wanted to start off this evening by saying good evening, and then also thanking everyone for just the really hard work that we put in last week. I always think after MLK Day in the height of service and thinking about service and where we're at. Thank you for all the service that you guys have put in this work. I know that it's been a lot, a little bumpy road at the beginning, but I think we're making headway into our journey together. And so I just wanted to say thank you for that and just the patience and perseverance you all have with this process. So thank you. Tonight, what we're going to do is we're going to go through vaccine distribution in Oregon. We'll have some time to ask questions of OHA staff and look at having our first mini discussion. No decisions will be made tonight on anything at this point. And so all decision making will be happening on Thursday if there's something that we need to do. So at this point, we want to welcome everybody. We also want to encourage folks to go ahead in the chat. If you go ahead and put your pronouns in there, and I think that will be a great way for us to do a quick kind of attendance, see who's here with us. I go by she, her pronouns, and it's great to be here with you guys this evening. So welcome. I'm going to turn it over for our first presentation of the evening. We have vaccine distribution. I also want to pause for a second to see if folks had any questions or OHA staff, if there were any other to-do things that I'm missing, if there was any piece. If not, Kara?
Oh, Charity, you were raising your hand. Go ahead.
I did have a question, and I'll just say it because I don't know. When we were making our list last week and we said the term BIPOC, I was asked, does that include Japanese, Chinese, because it's not specifically spelled out, or can you clarify that for me? Or how would I answer that question to people wondering if they're included in that category?
I can answer that. The summary that we came up with is 4 specific groups. So Black, Latino, Native American, and Pacific Islander. Those were the specific groups.
That's what I thought. We had mentioned the groups, but I just said I would ask. So thank you.
Thank you.
However, BIPOC does include people of color. So if a person identifies as a person of color, the POC part is a person of color. So anyone who identifies as a person of color in that Black, Indigenous, person of color acronym, that's a matter of self-identification.
Okay. Okay. Thank you.
Yeah, but for the purposes of the VAC, those 4 were specifically identified, yeah. Of the vaccine allocation, sorry.
I have a question by Suring in the chat already. It says, what is the best way to get Oregon vaccine related news? As members of the VAC, we get asked questions about vaccine rollout from our fellow peers and community members. Can VAC get updates about the vaccines via email? Thank you for your question, Suring.
So this is Kara, and I think I have a couple of options. So if you are getting asked by others where to get the most up-to-date information about vaccine in Oregon, we will make sure and follow up to give you the link to our website as well as the link to our data dashboard. I think these Tuesday night meetings are another place to have conversation more in real time about the types of things that are happening in operations. And that's actually part of the conversation that we're having tonight. And certainly, if you're getting questions and you would like OHA to provide some information to help answer those questions, always reach out to us by email or phone.
Great. Thank you, Kara.
One thing I wanted to add was the Oregon Health Authority COVID vaccine website is up and live, and also your specific county. A lot of counties actually have email lists that you can subscribe to, and they would have county level information and events.
Super.
And do have a question regarding
Sure.
we're getting letters or emails from certain trade groups. How should we handle that? They're obviously trying to advocate for their position in terms of vaccination. So how should we do or handle those type of letters or emails?
Yeah, that's a great question. I know that for some of those letters and they're asking you to support a certain group and whatnot. I know that we've also forwarded those into our comments piece. Is that correct, Kara? And so those would all be public comment as well. And so that can be forwarded to any one of our staff that you've all been working with, Jamila, Kara, Kristen. Any of us really can move that forward and put that within the public comments. Anything else to add to that, Kara?
Thank you.
I had one thing to add. So a lot of the public comments coming, Kara, is also for deliberation by the VAC when we get to the frontline workers category, correct?
Yeah, I would say most of the letters that we've received are from that. And another way, perhaps, just it would be good, and we can put this in the chat, is for folks to forward those to the Vaccine Advisory Committee email. And then we can get those compiled for comment and review. For public comment.
Yeah, so that way you're not the only one that has to read that, Maren, but we all get to read that. Has it been like 50 pages plus these days?
So the emails, we might get emails separate from what you're sending out to us. Okay. So if we get
I've just been sending everything to the COVID, saying thank you, and forwarding it on.
Yep.
Same here. Just a quick question. Is someone compiling, sort of breaking those down and compiling them, enumerating them for frequency?
Yes, I believe that our OHA staff, they're doing that. They're compiling all of that for all of you. And then we put all of that together and forwarded that to you all so that you can see what public comment has been made during the time that we've been meeting.
I'm sorry, I was asking a little bit different question. Is somebody categorizing them like people that are advocating for this group or this occupation or this industry, or if you're talking about just sending the raw comments?
So George, what we have been doing, we get upwards of hundreds of comments per week. If you've taken a look, I'm sure you've seen how long the PDFs are. And so what we have been doing, just because each of those comments also needs to be redacted so that we don't share any personal information that can't be disclosed, we group them into different groups of populations and then provide a kind of a half-page summary of what is included for each of those groups based on that week. And that's probably about the level that our staff are able to compile on a weekly basis at that volume, but hopefully that gives enough information about what's included in the packet.
Thanks, Kara. I didn't want to reveal any slothfulness on my part, but the prospect of reading hundreds of these seemed daunting. Thanks.
Yeah. And then Rachel had a comment too that actually suggest this one, which is specific to the COVID vaccine advisory. So that particular email address is in the chat as well. So that would be another place that you can send that. And then Suring, I've received a couple letters over the weekend as well. Are these letters being forwarded by OHA? I wonder if all of us are receiving the same letters. And thank you, George. Yes, compiling them and categorizing them would be great. I received one letter addressed to me from a personal email. All right. So for your question, Suring, you're receiving a couple of these letters. Are these letters being forwarded to OHA?
I could chime in. So I have been receiving a couple of trade and also some that are addressed directly to me, but I wasn't sure if OHA was actually forwarding these letters to all of the VAC members or if we are being seeked out individually and receiving these letters. If that's the case, is there a process for us to upload these letters or kind of forward them in categories so everybody has access to all the letters we're receiving?
Right. And so I think that goes back to what Kara was saying, that we collect them all. We're not forwarding anything individually to VAC members. And so we do it collectively all at one big bunch, and then we send it forward to you all so that you get it all at one time. So if you're getting these separately, that's probably people seeking you out and trying to get that information to your eyes. And so what we'll do is, again, we'll collect all of that information that we get from all of the different email components, and then anything that you all get individually, you can forward that to us as well, and then we would use that and then send it as a bigger PDF file to all of you before Thursday's meetings. Does that sound right, OHA staff? Yeah. Okay. So one more, go ahead. Says, please forward any emails you receive about vaccine sequencing to COVID vaccine advisory at DHS, that email site there, and we will respond to the sender and compile weekly. Zenya, please.
Yes, no, thank you. Can someone summarize what is the current state of sequencing and vaccine? Because I'm also getting a lot of questions and I feel like it's changing rapidly. What is the most current state? Who is prioritized? When is the next group going? Is this an appropriate time and place to ask that question?
Sure, do you want me to chime in and answer that? New?
Yes, please.
Okay. So the current right now, in a general sense, we're in 1A. 1A broadly contains healthcare workers. That includes healthcare interpreters. It includes folks with intellectual and developmental disabilities and those who are serving them. It includes traditional health workers. And so that's that broad definition. There are, what will follow that, generally speaking, is those who work in education setting, childcare settings, and early learning settings. The date for that transition, generally speaking, is January 25th. There are some counties, however, though, that have went through their 1A population and either have plans or have begun vaccinating their education, childcare, early learning setting workers. After that, so 1A, then there will be folks who work in education and childcare settings. After that, we're going to go to 80 plus and then move down the age range. What has happened, I think it's happened between the last time we met, a lot has happened. So, but anyways, what we learned is initially we thought we were going to get many more doses from the federal government than we ended up getting. And so when the announcement was made around 65 and older, that at that point we thought that we were going to have hundreds of thousands more doses than we end up having. So we say that to say that the process is going to take longer than we anticipated. So that's generally the sequencing, and the governor has announced those decisions with education and childcare as well as 65 and older. the Oregon Health Authority talked about last week in the press, that we're going to, and really learning from other states who have done maybe all of 65 and older. We're going to start with brackets and cohorts of age based on vaccine supply, and then go down 5 years, so on and so forth. That could take a number of weeks. And then we're looking at the rest of folks in 1B, which is where the Vaccine Advisory Committee recommendations come into play.
Great. Thank
Rachel,
you.
this is Muriel. I just have a quick question. I noticed in the slides that there's a document that talks about obviously the date for the 80 plus, but then it's to be determined for the other 3. But on the front of the Ben bulletin today, they put dates for all 4. And of course, our phones were ringing off the hook. So, and they said they got it from OHA. So I haven't seen it with those other dates on it though.
We were trying to figure that out as well.
Oh, okay. It wasn't just me. Okay.
No, thank you for the reminder though. The date that was put out to start the 80 plus is February 8th. Those other dates, to my knowledge, have not been put out, but we had heard reports that there were press that was reporting on different dates. So I know our communications people were trying to track that down. At this point, okay. I can say with all honesty, I have not heard that we are setting forth those dates, but rather we'll be looking at what's the vaccine supply and when have we sufficiently gotten through whatever age group that we're currently in.
Oh, okay, great. Yeah, it was on the front page. So
yep. Both Kristen, hold on a second. Both Kristen and Shimmy had put some websites on in the chat for another place to look for that information with some good visuals. Kristen, you had your hand raised. Did you want to add something?
I did. And it was a little bit kind of on top of Xenia's comment. And I don't really have a question, but I just kind of want to express a comment or a concern. And I think that this is the right time versus the Thursday group. Since this committee has kind of been charged the role of sequencing for the next phase of vaccinations, there's been not 1, but 3 groups have been prioritized. So since our committee came to be, we've now been told that prisoners were going to be in the next group because of lawsuit. And then we were told that it was going to be 65 and plus. And then educators, and then, that was backtracked because of supply issue to going back to educators and then grouping older adults. It just really, obviously the state has the authority to make these decisions, and I understand there's logistics and quick turnarounds, but I do just want it noted that these decisions are being made outside of the committee. So when I read 87 pages, and I did go through those 87 pages of public comment, there were a lot of questions to this committee as to why teachers were prioritized over the older adult population, which is different than what most states have gone through. And it just really led me to kind of wonder and question what this committee's role is when we're not really in the loop on these decisions that are being made outside of what we're being told is our task. So I just wanted to share those concerns that, again, I understand that there's timing, there are all kinds of issues, but we are getting questions as to, specifics, and we aren't a part of that process. And the process continues to go on without us while we have all these deep conversations about equity and diversity and inclusion, and then decisions are just being made.
Yeah. Thank you, Kristen. And it looks like several of our other VAC members, Suring and Dr. Duldalau, also share the same sentiment within the chat.
Could I ask for just a quick follow-up on the sequencing that has been determined? I agree, by the way, Kristen, I had the same thought. But going back to the sequencing that's already been determined by the governor. So when, for example, when 80 plus group goes live on February 8th, is there an implied assumption that there will be a second dose? So once one group's prioritized, that amount of vaccine is also reserved in the freezer for them to get their second round? Or are we going to go through just essentially go through these, and if there is vaccine for the second round, it'll be used, and if not, it won't? Is it clear what I'm asking?
Yes, Zhenya, it's very clear what you're asking. I'd like for somebody to address Zhenya's question, and then I'd like to circle back to the statement that Kristen brought up that I know many of the VAC members would like to be addressed as well tonight. So I don't know, Shimi, can you answer
Yeah, I
Zhenya's
wanted
question?
to clarify the question. Zhenya, are you asking that when we get through the next priority group, if there's accounting for the fact that this group will need a second dose? And so not exhausting the entire vaccine supply so that there is a second dose available?
Yeah, essentially, as each group is rolled out, obviously each group needs 2 doses. So it's part of the operation saying, all right, 80 plus is going live now. That's 50,000 people. So we're setting aside 100,000 doses, 50,000 are defrosted, now, and the other 50,000 in the freezer because we know 3 or 4 weeks later they'll come back. Is that part of the prioritization, the reserving the other half that should follow? Or is it not part of the operation?
The reserving is part of the process. We actually have a slide that gets into some of these specifics because the reserving actually happens when the way the vaccine is even allocated to the states. It actually comes specifically as prime, which is first doses, and boost, which is the second dose. So they're allocated based on the previous 3rd week's numbers, right? So Moderna has like a gap of about 4 weeks between doses. So the feds know to send the appropriate number of doses because they know how many Moderna doses we were given out as a first dose 4 weeks prior to that. So that's accounted for by the states as well. So it's actually accounted for on the supply side as well.
Thank you.
Thank you. And then let's really have a little bit of a discussion about Kristen and what you brought up about, the VAC made the decision, some nice decisions on Thursday, and then the next day the press release comes out and talk from the governor's office about who's next. So where does that leave this group and the decision-making process and things that we've you all have come to agreement with? And that's what I'm hearing. Yes, Kristen, more or less. You said it much better than I did, but how would we like to move that discussion forward, or if there's folks who can address some of the things?
No, can I add just a point to what
Please.
everything Chris earlier stated? So I feel like as being the VAC members, people really look up to us or ask us for any updates or whatever it might come. But we're learning along with all of our community members of all the updates through Twitter or for the Oregon Health webpage. And we're like, we don't have any other answers to give you, and these are not the decisions we're making. So it feels like we're just figureheads, but all the decisions are being imposed on us. So not quite sure what our role is. And that kind of puts us in a precarious situation or positions because people are still expecting us to advocate for them.
Yes.
Yes. I agree with that. I think that you feel like you're here to help the governor or the state make decisions on how to do the sequencing, yet that's getting done, and what we're doing doesn't seem like it matters, because they make the list and then, oh, by the way, you're what you shows is now no longer needed, or they don't say it, but that's how you feel. That here we did work on Thursday, and yet,
yes,
yeah, it's not being recognized.
Yes. And if we went back to the charge of this group was to make recommendations for the next group of folks who were put into the sequencing, and yet that gets bumped based on, on what, right?
I have a slightly different take on it. So I absolutely agree that that's exactly what's happening, by the way. I'm not sure that it's such a bad thing. I think it's inevitable. Things move very, very fast, and the governor has to make very quick decisions. Like when we learned that there's not the second, there's not nearly as much vaccine coming. It was an urgent decision that needed to be made very, very quickly. And we're not set up for that kind of urgent decisions. And further, I have to admit that I have struggled with the role of this group, but for a different reason. I think that the true priority of vaccination should be led by public health experts who really, truly understand population health, vaccine distribution challenges, really understand the epidemiology of this. And I think a group like our group could bring really unique and needed expertise in how to reach underprivileged communities with these vaccines. Because even Group 1A, as much as it's been prioritized, I know a great deal of members of the 1A that have no access to the vaccine. They have no idea where to get that information. And they have a lot of hesitancy about it. And so they're not getting it, even though they've been prioritized. So I personally feel that this group could be most effective if we recognized that the governor is going to act fast and sometimes override this group because this virus isn't listening to anybody. It's doing what it wants to do. But that our role is at every step of the way in using our expertise in our respective communities to see how to get that to them sooner. I mean, I also think should have input in the priority as well, but I think the others are primary role. And frankly, I haven't yet seen any real focus on that. So 1A people are going unvaccinated that are minorities, that are, same groups that we're representing within each one of those priority groups are already suffering because they can't understand how to get this vaccine. So that's where I see this group most useful going forward personally.
Thank you, Zhenya. I know that definitely part of the hope that OHA has to utilize this group is to work with communities and talking about vaccine hesitancy, communications to populations that we just frankly haven't been working with as closely as we could, And so I want to go ahead and turn it over to Rachel. And Rachel, you have some thoughts about the concerns that the VAC has brought up?
Yeah, and thank you. I appreciate Kristen, you raising this and everyone else for lending their voice and amplifying it. And I think, clearly you're right that there have been a number of decisions that have been made. And I will say that those of my colleagues I know at OHA have really wrestled with this, and our intent the entire time was we need to be clear on what decisions the VAC is making and that those are real decisions. And I do think there's a part of that sometimes, and this is kind of a bit of a balance, that if a decision is going to get made, have it be made so that by the time you all kind of came together. So I feel like the education and school settings, that was an example of a decision that was made before the group came together. What we really wouldn't want is to bring folks together and say, hey, it's your choice, but don't you really want to prioritize this group? Because that's what we really think you should do. So I think that was sort of one piece is trying to determine, are there decisions that the governor, for example, wants to make before the vaccine advisory group, or because that was the right timing to make. So that was kind of one I just want to acknowledge on the education piece. Definitely a couple of the other decisions I think were things that weren't necessarily anticipated, or at least the way that they came in. The adults in custody, as you mentioned, where there was some conversation around settlement and litigation, and the ask then was that the advisory that you all prioritize adults in custody in 1B. So just once again, want to acknowledge that. And then I don't know, I was going to say wingdinger. I was like, I should find a different word to say this, but I think definitely the 65 plus came in as a surprise as the federal government announced that they were altering some of their recommendations. And that did become, a decision that was made outside of the Vaccine Advisory Committee. And so I just, once again, want to provide some of that information, not to in any way invalidate people's comments or concerns, and really to lift it up and provide some more context, and say, I can tell you that we all, and I understand there's varying perspectives, right? Like we heard that there should be public health people that make these decisions. I'm a public health person. And when and I work with phenomenal epidemiologists and doctors and a group of folks, but when we look at our data and and particularly in health inequities, we cannot be doing this all on our own. And we do need various perspectives. And ultimately, you know, this pandemic is going to take all of us. So that's why we really, as public health people, push to let's get the most diverse committee that we can. Let's get the best perspectives that we can. And acknowledging that there's a variety of different expertise. Sometimes that's in public health, sometimes that's in lived experience, sometimes that's in a variety of fields, but we need all of that. And I do think that there is definitely opportunity, and particularly once we get past this push of the sequencing conversation, to talk about how do we mobilize culturally specific efforts, how do we reach folks that we're not perhaps not reaching, or that get left behind, and how do we make sure that those strategies, and I guess I shouldn't have said it as an either or, like first we do this and then we get to that. They are intertwined. So I do think that that is the power that this group brings, both in the conversations around sequencing and in conversations and how to reach people. And I want to apologize. You all are working so hard, and you know, it's definitely the last thing that we would want, that people feel like, wait, I'm powering through all these meetings. You know, I think I heard the word or saw in the chat figurehead, and that's, you know, that's definitely the last thing that we would want, and we'll really fight to make sure that your role is preserved. And one of those things, to the earlier conversation about getting pressure from people about, or getting asked about decisions you didn't make, I think we can do a much better job really clarifying that. So whereby we can put out communications or media messages that will hopefully alleviate some of that pressure. That's something we can definitely do, but I'm open to other suggestions there.
Hi, yeah, Rachel.
And I would just want to acknowledge. Go ahead, Maren.
No, I just want to thank you for your comments, Rachel. I do agree. I think everybody, you know, is bringing excellent points and conversations. You're right. It's very challenging, I think, for everyone. I mean, from OHA, from community members, from all sectors. I think it's a very challenging process to go through for everyone. So I'm not trying to blame anyone, but I do believe that one of our goals as part of the committee is to talk about these issues. I mean, today I'm assuming distribution is a big issue. And I know that definitely all these comments I think are valid and I think are great. And I think definitely we should discuss, but again, given limited time, I want to make sure that we talk about distribution in terms of what the plan is or what the issues are regarding that, you know, for the next time that we have. I know because part of the conversation was talking about distribution. Is that correct, Neil? To talk about.
Yeah, tonight's is about vaccine distribution. So you all get an idea of how that works here in Oregon. So that's what we have on tap.
Because I do have
we can start that. I agree with Maren. I think that's a really interesting conversation. So I hope we can have the presentation, because I agree also with Zhenya that this group can advise you on how to reach the populations we're trying to get to if we know about distribution.
Correct. Thank you.
So it sounds like we can take a pause for a second and shift into the presentation around distribution, Shimmy. So thank you.
Okay, yeah, this is a high-level presentation. I think, as we mentioned before, there's some kind of up-to-the-minute decisions happening, especially with some of the changes in supply, as well as the federal government's recommendations. Next slide, please. So this is an overview of our vaccine dashboard. Some of you may already have checked this out, but I've added the link on the bottom of this slide as well. This is actually not the most up-to-date figure of number of people vaccinated. We've vaccinated at least 60,000 people more since this date, but this is just generally the kind of data you're able to get from this dashboard. Next slide. So how is the vaccine being distributed? So the current distribution for phase 1A started with hospitals and hospital-based systems. They received the majority of available vaccine in the first few weeks, followed by the skilled nursing facilities, which got approximately 20% of the available doses in December. So the skilled nursing facilities were actually distributed the vaccine through a federal program, which was running in parallel to the hospital-based vaccination. And the skilled nursing facilities, as well as long-term care facilities, as defined by acute care long-term care facility beds, were actually wrapped up in this program. And so it's 20% for SNFs and 40% of the doses for long-term care. And this again was running in parallel to a third program, which is also organized by the federal government, and that's to tribal health divisions, including Indian Health Services and urban health centers. In addition to this, towards the later part of phase 1A, we started distributing vaccine to local public health authorities to increase the net by which the vaccine was distributed outside of hospital-based systems and onto outpatient facilities and their providers. This included a separate reach out through a local public health to emergency medical service and first responders who were categorized as a 1A group that was unique to Oregon and not part of the ACIP outline. In addition to that, to federally qualified health centers who were able to receive the vaccine and then vaccinate all of their staff and providers. And finally, to urgent care centers who also receive the vaccines. So these urgent care centers specifically are non-hospital affiliated centers who are able to receive the vaccine and then vaccinate their staff and providers. So the challenges we noticed for distribution was how to effectively get providers to sign up in a way that was timely and efficient and also pervasive, that all providers were able to be, were allowed to be in this catchment of signups. Cold storage needs, especially for the Pfizer vaccine, which is where Oregon prioritized getting the Pfizer vaccine to hospital-based systems that actually had the ability to store to -70 degrees Celsius, which a lot of outpatient facilities were not able to do. And then minimum dosages. So the minimum doses for allocation, because the allocation comes straight from the federal government to the sites receiving the allocation, they do not sit at the state public health authority first for redistribution. So Pfizer needs to be sent out in doses of 975 per shipment, and Moderna in shipments of at least 100 in increments of 100. So 100, 200, 300, or 400. Next slide. So this is just an overview of the state of Oregon and our catchment and uptake of facilities that actually enrolled in this program, by which the feds allocated vaccines directly to the states. Oregon is in dark blue, so about 95 to 99% of all SNPs were enrolled and allocated vaccines as of 11/15. And that, sorry, I'm still talking. So that actually has increased to 100% in the next couple weeks since vaccine rollout. And so we're several weeks into this program. Next slide. What factors have affected how vaccines get into arms? So there are few unique challenges to this specific vaccine because this is an mRNA vaccine and this is our first clinical experience with an mRNA vaccine in a large-scale population. Cold storage and management of the fragile vaccines was one. Scheduling the vaccine and appointments was another. And the main reason for this is because the vaccine has, while the vaccine itself, the administration itself doesn't take very long, there's upwards of 15 to 30 minutes of observation periods required because of the risk of allergic reactions that come after a vaccine has been administered. Space requirements, and especially with physical distancing. So space requirements both to store the vaccine as well as to administer the vaccine without, while avoiding crowding to reduce the risk of COVID-19 transmission. And again, like I said, the scheduling includes that operational piece of incorporating observation periods post-vaccine. So one challenge that this posed was the number of people vaccinated per hour. So we started out pretty low across the state of about 6 people vaccinated in a single hour, depending on the number of vaccinators available at any one clinic or event, and upwards to now we're doing upwards of 1,700 in a single facility over the course of 8 hours. So it's gotten much better. Side effects and monitoring are necessary. The holidays actually posed a little bit of a delay in terms of distribution and allocation and planning, just because the first doses of this vaccine came out around December 11th and 12th, so just a couple of days before the Christmas and New Year's holiday. There's a data lag from Tiberius, which is the reporting system that collects, Tiberius is the reporting system by which allocations are scheduled and recorded, and our alert system actually logs how many vaccines are administered and any personal characteristics related to each vaccine administration. There are limited outlets to give the vaccine. So when we started, because of the delay in provider sign-up, we actually noticed that the bulk of our vaccine providers were based in hospital-based systems, and this included additional weeks of outreach and additional provider sign-up to expand this reach. And additionally, the last restriction that we've noticed is because we're using a phased approach. This has restricted how many vaccines we're able to give, because we need to make sure that we need to stay within a specific phase. And this was partly the reason by which we collapsed the phases 1A, groups 1 through 4, to start allowing groups 2, 3, and 4 to go ahead simultaneously while group 1 was being vaccinated. This is around the same time that Governor Brown announced her new goal of vaccinations as of the early part of this month, of targeting Oregon's vaccinations at 12,000 vaccinations per day to allow for timely vaccination of the entire state's population. Next slide.
Hi, Shimi, I have a quick question.
Yeah.
So each sector, how do you give in terms of allocations a certain amount of doses for each sector? Is there like let's say hospitals, how much you're giving to them is based on what? Region, number of infections, what is that formula in terms of like certain counties, certain hospitals, or whatever, they get more than others? It's based on what are those factors that you base allocation on as to what exactly they get, what they get?
I think in the early days of allocations, they were actually allocated a full 975 doses, regardless of the size of the system. And this led to some of the discrepancy, right? So some of the counties might not have as many staff, but this was a requirement by which the feds will actually ship the vaccine. So that was actually one of the early challenges that we faced, because they had to be shipped in quantities of 975 minimum. And most of the time they would never even receive a second shipment of 975, because that was just already a big number. And smaller counties would use that vaccine up a lot faster. And what was happening was that they would have vaccinated their eligible population in group 1, which are hospital-based staff and providers, and they just wouldn't be allowed to progress through the groups. And so that was partly the reason that we had to collapse the groups, because they had excess vaccine sitting and not enough people to vaccinate.
Okay, thank you.
This goes into, and part of the other challenge that we've noticed with our distribution so far is vaccine hesitancy. There is understandable historic and contemporary medical and public health distrust as a result of injustices that have occurred both in past as well as present times. Trust needs to be earned by public health and medical providers, and access to the vaccine has to be backed up by providing culturally and linguistically competent care. One dramatic example is in a lot of the large vaccination events, just even anecdotally, people have noticed how there's a severe discrepancy between the number of white identified folks and people of color attending these mass vaccination events. And that really speaks to, just because you create the access, you don't actually create the uptake. Next slide. How has community feedback influenced this process? So far, the process has been, we gather feedback from hosting listening sessions and community dialogues. Members of the public reach out to OHA staff directly, and that's incorporated for you all to see in the compiled public comments that you receive by PDF. Local public health authorities have a call with OHA every week, and they provide feedback directly, and hospital and health system as well as unaffiliated providers have actually provided feedback throughout this process. Next slide. So some lessons learned, and we did get some feedback from Leslie Sutton saying that this lessons learned slide actually only addresses the lessons that we learned as a result of our hospital-based and non-hospital-based provider populations, as well as congregate care. It doesn't actually include some of the lessons learned, just incorporating our adults with intellectual and developmental disability. So that's one thing to note. But even in our hospital-based distribution, what we did notice that it's very different from distributing large numbers of influenza vaccines, which is where the lessons from our last epidemic came to light. So that with the H1N1 pandemic, there are still large differences in the way this vaccine is distributed, both because of the storage and shipping considerations, as well as the observation periods required. Scheduling, physical distancing, and observation periods were the main impacts. Pfizer was especially complex because of the shipping and storage on ultra cold chain environments before they can be stored in a regular freezer. And then other operational complexities due to the need to prioritize. Some groups were simple, hospitals, EMS professionals, as well as long-term care, because they're either in the form of large incorporated health systems with easy access to the vaccine, to separate clinics, as well as multiple facilities within a long-term care campus. But other groups are especially complex, such as unaffiliated healthcare providers. And this specifically talks to traditional healthcare workers, community-based healthcare workers who are not actually incorporated in a larger healthcare system. Next slide. So some action steps that OHA took as a result of the lessons learned from the first few weeks of phase 1A was to change phase 1A sequencing, like I said, to move away from strict sequencing of the 1A group to collapsing the groups where possible. And some counties are able to progress through the groups faster than other counties. And providers are encouraged to follow the original sequencing plan when they consider when they can and cannot progress through the groups. And finally, to make all 1A eligible individuals in groups 1 through 4 to receive the vaccine at this time, at least from a state level, even though realistically or operationally, it would differ by county. Rural counties are able to progress through to group 4 now versus larger counties are still vaccinating groups in 2 and 3.
This is Leslie. I just wanted to add a little bit more context to my earlier feedback. I appreciate that this group is now looking at what distribution actually looks like. And given our work last Thursday when we said who would be in phase 1B, I think it's also important to look at how the implementation has gone thus far for groups that are not as easy to find, which, as you mentioned from my earlier comment, includes the developmental disability system. And the reason I thought that that was so important to talk about today is that the groups identified in phase 1B likely will have similar challenges to those that the developmental disability community faced, which is the typical chain of how vaccines and medical supplies are moving in Oregon isn't set up to specifically address the people with developmental disabilities, because it is looking at a top-down approach where you are looking at how is our typical healthcare system reaching people, instead of looking at and starting with what is the population we're trying to reach and how do they get information, how do they get vaccines. So one thing I think a big lesson learned is it took several weeks for us to really iron out with OHA that you need to include developmental disability case managers. That's how you find where the people are. You need to start with the people, find out where you find them, and then develop a distribution system around that, taking into consideration all of the unique needs and the different people included. So that's just my takeaway for this group to remember, is that it's really important to start with the person and the community, and then start looking at what distribution looks like instead of opposite.
You know, I agree with you, Leslie. I think it's a part of our charter to develop a strategy to reach these hard to reach populations, disability or BIPOC or otherwise, in terms of different strategies, because we know that you're right, they're not going to come to these mass big events. So how do we develop a strategy to target specific groups where they're at, and working with farm workers, working with people with disabilities, working with other community members? So it's part of our charter to help OHA develop a strategy in terms of outreach, marketing, campaigning. So for example, we did a focus group yesterday with Latino community members, and about 70% honestly said they're not going to take the vaccine right now. They're going to wait and see. There's a lot of anxiety and fear about the vaccine itself. And so a massive education, outreach, marketing campaign needs to be in place now, not wait until they're ready to take the vaccine. So all these things that we're talking about, for us as a committee member, we'd love to discuss and hopefully come up with ideas So for example, right now we have the COVID-19 grant program. All these CBOs are part of the grant or can be good networks to work with in getting the word out and developing vaccine events or whatever that is for us to get the vaccines to the people that really need the vaccines or their hard to reach populations. Thank you.
Yeah, we're definitely going to be talking about that in the days to come too, both Leslie and Marin. Thank you for bringing that up. Vaccine hesitancy, communication, how are we reaching these populations that are hard to reach? And so definitely that's part of the plan that we're hoping how to utilize the VAC members more effectively.
I'd like to add to that too. When we talk about the older population, I get concerned about splitting them into 5 groups and the distribution, because a lot of older people in these age groups are not going to be able to get themselves necessarily, have the technology to make an appointment or get themselves to a group distribution. So that needs to be taken into account with our older population.
I second that from Ruth for speaking for the older adult population as well. I was immediately concerned when I saw the group phasing of age requirements for the older adult population. That's going to be a struggle, and particularly folks that share households with, again, older, multi-generational or older spouses, younger spouses. It's going to be an issue, and logistically to sort people out by those age differences.
Yeah, we're definitely going to bring in more conversation from our community engagement team, and that we're hoping to do that next week, Tuesday. I know that we're running really short on time. Can we go ahead and have Shimmy finish and then take maybe even one last question or comment at the end of this presentation? Thanks, folks.
So action steps, I think we just talked about this. So we went away with strict sequencing, and also different counties can go through the different groups 1 through 4 based on their pace of vaccination. Next slide.
This is Kristen. Are you seeing the slide changes made by OHA?
I am.
But okay, yeah, it might be my internet. Sorry. Last time it just kind of made that change after a couple seconds.
Shimmy, this is the slide.
Oh yeah, now at the infographic, updated visual.
You are now 1 slide behind us.
Okay, now I think changes made by OHA. Right?
Yes.
Okay. So other changes made by OHA are to enhance delivery to nursing home staff and residents by activating Part B of the Federal Pharmacy Partnership. So, and basically Oregon did this by working with the CDC and Walgreens, Kinsanis, and CVS, who were the federal partners for Part A. So Part A and Part B, they really just refer to the types of facilities that were eligible for vaccination. This is again part of the federal allocation program. For Part A of the federal vaccine program incorporated just acute care, long-term care facilities, as well as skilled nursing facilities. And with the incorporation of Part B, we were actually able to expand this population out to adult foster homes for older adults, adults with disabilities, adults experiencing behavioral health issues, and people with intellectual and developmental disabilities, as well as group care homes for people with intellectual and developmental disabilities, and behavioral health residential treatment homes and facilities. So
Mayor, I have a quick question. Are those pharmacies found in communities throughout the state, or are we missing some areas in rural Oregon where they might not be?
So to clarify, the way Walgreens, Kinsanis, and CVS are working are not by bringing patients or people to the pharmacy. These pharmacists are organizing vaccination clinics in these settings. So they're going to the setting to vaccinate.
And are they able to go statewide?
They are able to go statewide because they've already been leveraged by the feds. So what Oregon did is just expand the scope of their populations to include these facilities below. So they were already going statewide to provide the long-term care facility vaccination. So all Oregon did was to expand that eligibility to memory care beds in addition to all the facilities that you see on this slide. Does that make sense?
Yes, thank you.
Okay. Next slide. Other changes made by OHA, so to use retail pharmacies to get more vaccines to healthcare workers and other phase 1A groups. Like I mentioned, make more doses available to phase 1A workers by leveraging all available public health capacity. And that's actually by increasing staffing capacity, because another roadblock to getting vaccines out was actually having the staff to do it. So we've actually leveraged using our Servo, our volunteers, to do this work. And then also to speed the number of doses delivered to unaffiliated healthcare workers by supporting innovative partnerships. And that's actually with the use of large pod events, so point of distribution events organized by large health systems that can store the vaccine and therefore administer the vaccine to a larger population base. Next slide. Building priority groups has operational implications, and the main implications are we don't have enough vaccine yet to do a statewide distribution without having priority groups. Usual vaccination process still has to go through specific types of channels, hospital, pharmacies, and workplaces. And also giving vaccine by different types of groups means that the usual process needs to be changed because we're not going the traditional healthcare route whereby you go to your primary care doctor's office and get a vaccine that way. So this is actually a slightly different method of distributing vaccine. And compliance challenges. Pharmacies are not used to giving vaccines to some groups and withholding from others, and that's why we can't go through a retail pharmacy system whereby you can walk into a pharmacy to receive that vaccine. Next slide. Additionally, some other considerations and lessons that came out of this process is that for some groups, the distribution is more straightforward and has pre-existing pathways because hospitals can vaccinate their own staff. Skilled nursing facilities have pre-existing relationships with pharmacies for on-site vaccinations, and that's why these programs were able to be rolled out first. Vaccinating healthcare workers who are not part of large healthcare systems is more complicated and was a lesson for when we get to the general publics, like some of you have already mentioned. As a result, OHA will expand the number of administration sites and establish new collaboration to deliver new COVID-19 vaccines in new ways among our healthcare partners. The ways in which OHA will do this are actually still in discussion. So some of these ways in which we will be delivering vaccine will be updated in the weeks to come. There was a question from Zhenya asking how are phase 1A populations actually getting the vaccine, and they're actually getting it in a variety of ways. One is through large events held by healthcare systems in county fairgrounds or other large public places. People are also getting it through the Part B of the federal pharmacy program, whereby they're expanded to congregate care facilities. And in addition to that, long-term local public health authorities are actually scheduling events for vaccines, independent of OHA's events as well. And that's why I said if some of you would like to, it might be useful to get on the email listserv to your local public health authority. Next slide. Some of this data comes from our tribal partners as to how the vaccine has been allocated for both urban as well as Indian Health Service populations. Federally recognized tribes are individual sovereign nations, and the United States government has a unique legal relationship. This relationship is derived from political and legal relationship that the tribes have had with the government is not based on race, and specifically there's 573 federally recognized tribes. Next slide. Tribal governments are separate sovereign nations with powers to protect the health and safety and welfare of their members. The sovereignty predates the existence of the US government in the state of Oregon. The members residing in Oregon are citizens of their tribes of Oregon and since 1924 of the United States of America. And the governments have reservation or trust lands created by treaties or federal acts. Next slide. Tribal sovereignty is the inherent authority of the indigenous tribes to govern themselves within the borders of the United States of America. The federal government recognizes tribal nations as domestic dependent nations and has established a number of laws attempting to clarify the relationship between federal, state, and tribal governments. Next slide. And additionally, the federal Indian trust responsibility is a legal obligation under which the United States has charged itself with moral obligations of the highest responsibility and trust towards Indian tribes. It's also a legally enforceable fiduciary obligation on the part of the U.S. to protect tribal treaty rights, lands, assets, and resources, as well as a duty to carry out the mandates of federal law with respect to federally recognized tribes. Next slide. The state of Oregon also honors tribal sovereignty and recognizes the right of Indian tribes to self-determination, self-governance. Next slide. So if you can see, it's cutting off for me a little bit, but Oregon's 9 federally recognized tribes reside in these counties around Oregon. Next slide. And the tribal governments here are listed here. Next slide. So vaccine planning across tribes and tribal communities, they conferred twice on the 22nd and 29th of October. The tribes chose to receive COVID-19 vaccine allocation through the IHS program. The vaccine planning unit has held discussions with the IHS vaccine planning team, as well as Next Door Incorporated and the Columbia River Intertribal Fish Commission. Meetings with tribal leaders and health directors were held to determine allocation preference for Pfizer versus Moderna and to revisit the allocation process. Next slide. So Oregon will actually send vaccine to one community hub to provide vaccine to tribal community members along the Columbia River, starting with Zilillo Village, and in addition to these other facilities outlined above. Next slide. And each tribe has the sovereign authority to determine its service population and its priority groups, independent of Oregon's priority populations, who they receive the COVID-19 vaccine distribution from, either the federal or the state allocation, and also how they dispense them to their populations. Tribes submit the responses to the following questions each week. What is the amount of vaccine requested for next week's shipment? And are you planning any large vaccination events that we need to plan for? Next slide. I think we missed some questions along the way. New,
There
do you
was
want
a
to?
question. Yeah, there was a question specifically. Zhenya wanted more specific information about who people can call if they want to know if they can find out where they can go get vaccinated if they are part of 1A and are eligible. Zhenya, I'm going to suggest that our OHA staff will get that information to the entire VAC and email that out, and where we can go, because I know we're over time now, and so I want to, but I do recognize that question for you. And then there was a couple comments earlier between Charity just asking that for OHA staff, and specifically, thank you, Rachel, for responding to her. Just the piece about if in the media, when the governor's office, I don't want to miss this here, suggests that if the governor is going to prioritize groups outside of VAC's recommendations, then perhaps that can be noted in the media releases. Another request would be a brief notice to the VAC members so we can be aware of changes and be prepared to address that with community, with responses. And Rachel, thank you for responding to that. And thank you very much for that. Yes, we can be clearer in our communication and make sure people are aware of any modifications and have information about the situation or rationale. That should have happened, and I take accountability for that, and regret for the issue it's caused all of us. Thank you for diligently serving our state. And then I believe there's a couple of web links for you all too on sequencing and numbers to call based on the county in which you all reside. With that, I know we ran a little over time tonight, but I think the robust conversation about where folks are at, you know, a week and a half into the work, thank you so much. We will resume on, what's today, Tuesday? We'll resume on Thursday morning, 10 o'clock. And so be on the lookout for more information from OHA staff with regards to materials and additional information. And for the good of the order, thank you, everyone. Have a great night. Rest up.
Thank you, Neil. Thank you,
Thank you.
everyone.
Great discussion. Appreciate it.
Thank you.
Good night, everyone.